Well, hello, this is Jennifer Lee. I am a DSW student at Tulane University, and I'm going to be presenting a mock evaluation proposal for the Central Valley Crisis and Suicide Prevention Hotline program. Again, this is just a sample mock evaluation for purposes of a college class. So here we go. So I'm from Fresno, California, so I wanted to essentially contribute back to my place of birth by researching a program there, and especially around the holidays where depression, I feel, is prevalent. There's a high propensity for suicide. So this is the program I'm going to be proposing an evaluation for. Suicide is one of the top 10 leading worldwide causes of death, with 800,000 recorded suicides yearly and an estimated 16 million episodes of self-harm yearly. Suicide is the second leading cause of death in people ages 15 to 29 and the leading cause of death in young women. Suicide prevention is now a policy priority in many countries, with some countries implementing national suicide prevention strategies with guidance from the United Nations and the World Health Organization. However, globally, suicide prevention is still not a health priority. The effectiveness of individual interventions remains questionable. Optimal evidence-based approaches are needed to develop suicide prevention strategies, and further consideration needs to shift toward the evaluation of what does and does not work. Still, there remains a continual need to evaluate specific interventions and effectiveness of suicide prevention strategies as health policy initiatives. And this is, of course, according to Winfer, Nordentuft, and Lancet cited this 2009 and 2011, 2016 are the references. Additional statistics have been compiled by the American Association of Suicidology and include in 2016, 44,965 Americans died by suicide. The suicide rate has steadily risen since the early 2000s. There were 122.9 suicides daily in the United States, or one suicide every 11.7 minutes. There is one death by suicide for every 25 attempts. Approximately 1,124,125 attempts were made in 2016. That's one attempt made every 28 seconds. A 2016 survey found that 1.3 million people age 18 or older made a suicide attempt. Men accounted for 77.23% of all U.S. suicides. For every female death by suicide, there were 3.3 male deaths by suicide, but there were 3 female attempts for every male attempt. Recent research predicts that for every suicide, 147 people are affected, and 18 experience major life disruptions. Survivors of suicide loss grew by more than 269,790 in 2016. And across age, gender, and race, suicide rates in the United States have risen, and this is referenced from the research conducted by Drapio and McIntosh in 2017. In 2014, 4,214 Californians committed suicide, and 33,350 Californians were seen in the emergency department for self-inflicted injuries. The Mental Health Services Act was passed in 2004, requiring states and counties to develop an approach in providing early mental health prevention, intervention, services, and education to Californians, called the PEI. A coalition of counties then created California Mental Health Services Authority, CalMHSA, to provide support for service delivery and evaluation to inform decisions regarding continued investment. In 2007, California counties made suicide prevention one of their strategic initiatives, investing a large amount of the resources they received from Proposition 63, which is the Mental Health Services Act, MHSA, into suicide prevention hotlines. Under the suicide prevention program, Cal MESFA funded the creation of one suicide prevention hotline and provided funding for 3 to 5 years to enhance 11 existing hotlines. The goals of suicide prevention hotlines is to provide suicide prevent suicide in 2 ways. One, ensuring the immediate safety of suicidal callers, and connecting people who may be at risk of suicide to necessary, appropriate, and available resources. This is according to a citation from Acosta et al., 2017. They conducted a massive research. This is from the RAND Corporation. In 2011, CalMESFA asked RAND, a nonprofit institution that improves policy and decision-making via research and analysis, to evaluate its statewide PEI programs and suicide prevention hotlines it funded. RAND's evaluation of the 12 agencies in California with suicide prevention hotlines revealed recent evaluations of suicide hotlines used third-party evaluators who listened to live recorded calls and found that callers experience a reduction in distress and suicidal thoughts intent during the call. 62% preferred to call a crisis line when seeking help for suicidal thoughts, and there have been no studies assessing the need for suicide prevention hotlines in California, and also no statewide assessments of suicide hotline capacity, referenced by Acosta et al., 2017. The American Association of Suicide Duology is one organization that accredits suicide prevention hotlines, evaluates applicants in administration, organizational structure, screening, training, and monitoring for call responders, general service delivery, services available for life-threatening crises, ethical standards of practice, community integration, and program evaluation. In evaluations of crisis hotlines, it found that they use the American Association of Suicide Duology strategies to evaluate effectiveness, examine presence of crisis line support correlation with community rates of suicide, monitoring calls, and following up with callers after the call. CalMHSA provided grant funding for 3 years to organizations such as Kingsview Behavioral Health and others that used the funding to establish the Central Valley Suicide Prevention Hotline serving Fresno, Kings, Madera, Merced, Tulare, Mariposa, and Stanislaus counties. Several organizations using CalMHSA funding for their suicide prevention hotlines faced challenges in obtaining ongoing support after their CalMHSA grant ended. And this is according to Acosta et al., 2017. And I believe that Central Valley, the program that I'm going to be observing, they also were impacted when funding expired from CalMHSA. And so they're still maintaining their site, but of course it'd be wonderful if they could get more grants for their program. The Central Valley Crisis and Suicide Prevention Hotline, CVSPH, began in January 2013 with limited operational hours and abilities. In July 2013, the program expanded to 24 hours a day, 7 days a week, 365 days a year. In January 2014, the program received national accreditation, being recognized as a best practices call center by the American Association of Suicidology. CVSPH, Central Valley Crisis and Suicide Prevention Hotline, is also a member of National Suicide Prevention Lifeline, which provides interpreters for 150 different languages. The program is located in Fresno, California, serving California's Central Valley, a culturally diverse group of 7 counties: Fresno, Tulare, Kings, Madera, Mariposa, Merced, and Stanislaus. It is free and operated by staff that include volunteers to minimize cost and maximize efficiency. The program's trained staff provide a multitude of services for assistance and support that include provision of immediate support to keep people safe who are in crisis, have suicidal ideation or in the process of committing suicide by developing a safety plan, linking clients to resources, reaching out to callers with post-crisis follow-up to ensure their safety and their receipt of the help they need, supporting survivors of a suicide loss with a description for stages of grief, providing resources and education to people who are helping a loved one or a friend. They have a website in which they provide statistics and resource links for the needs of veterans, youth, and the LGBTQ community. Amongst just a few, there's many other communities that they help. They engage in media campaigning, press news releases, and outreach, to say the least. Again, there's many other things that Central Valley Crisis and Suicide Prevention Hotline they engage in. The program also provides resources for bullying, depression, domestic violence, drug alcohol abuse, interpersonal relationship problems, financial crisis, mental health concerns, self-harm, and situational crisis. It also maintains a Twitter social media chat forum for support and several YouTube videos for awareness. I actually watched one of their YouTube videos. It was wonderful. And then this program was featured in the news also. So they have a lot of outreach on social media platforms. California, the Central Valley Crisis and Suicide Prevention Hotline in Fresno, California is funded by California Central Valley counties and sponsored by Kingsview Behavioral Health Systems in accordance to the voter-approved Mental Health Services Act Proposition 63. It is a 501c nonprofit organization with a tax identification number, and they accept donations. And this is according to their website that I accessed this year, 2008, about a week or so ago. So now this is again my mock evaluation of this program. I'm a learner, and this is my disclaimer. This is my first time ever making an attempt to do an assignment like this, so I'm sure there's lots of room for improvement, but I hope that this is a good start, and so I gave my best. So introduction and stakeholder engagement. Suicide is an increasing global and public health concern. The Central Valley Crisis and Suicide Prevention Hotline is a program to prevent suicide, save lives, and to promote awareness and intervention for this epidemic. The program stakeholders include the program consumers, their family members, and loved ones, program staff, sponsors such as Kingsview Behavioral Health, accreditation organizations such as the American Association of Suicidology and National Suicide Prevention Lifeline, members of the community, and society. The stakeholders have jointly requested that a program evaluation be completed. A steering committee meeting to discuss the launch of the evaluation will occur, as well as monthly meetings with the stakeholders for engagement, investment in the process, collaboration, input, dissemination of information, areas of improvement, findings, and the participation in solutions. Overview of program model and problem definition. The Central Valley Crisis and Suicide Prevention Hotline is a no-cost nonprofit organization serving individuals in numerous counties that provides access to voluntary call responders 24 hours a day who provide crisis intervention, psychosocial support, and resources. This program is a member of the National Suicide Prevention Lifeline that uses Lifeline suicide risk assessment standards that provides mental health professionals and crisis centers in their network with best practices and resources for suicide prevention and mental health. The program follows Substance Abuse and Mental Health Services Administration (SAMHSA) funded evaluation for suicide risk assessment uniformity and practices for crisis call centers. The Lifeline Standards Training and Practices Subcommittee is composed of nationally and internationally recognized experts in suicide prevention who develop policy standards, guidelines, and practices for its crisis centers. It develops evidence-informed suicide risk assessment standards. It developed that in 2006 for suicide capability, suicide intent, and buffers. And Lifeline adopted these standards in 2007. In 2011, Lifeline released a policy for helping callers at imminent risk of suicide after Lifeline risk assessment standards, using active engagement by requiring hotline staff to make reasonable efforts to collaborate with callers at imminent risk to secure their safety, and active rescue, requiring staff to take all actions necessary to secure safety of a caller for emergency response, with or without the caller's consent. Skill sets are taught with living works, applied suicide intervention skills, assist training, as well as guidelines produced by the National Suicide Prevention Lifeline, in which the Central Valley Crisis and Suicide Prevention Hotline is a member. And this, of course, is referencing National Suicide Prevention Lifeline. This year, I received this information from their site. Existing research practice for evidence practitioner knowledge of program. There are similar suicide prevention hotlines that were evaluated in 2013 and 14 by RAND 2017, who completed a study of 12 suicide prevention hotlines in California, United States. According to RAND 2017, the privately run website www.suicide.org, it lists 90 suicide prevention hotlines in California with no hotline directories. I went on that website, suicide.org. I'm very impressed by it. Again, it does seem to be privately run, accepting donations, but very informative and necessary program. I think is amazing. It's available for the community. The Lifeline, that the Central Valley Crisis and Suicide Prevention Hotline is a member, is composed of 164 state-funded crisis centers in 49 states, 11 in California. The Lifeline assures centers are accredited and provided with training for best practices. Calls to Lifeline are routed to their closest center based on area code, with the goal to connect callers to counselors in their own state, where local counselors at crisis centers have access to community mental health resources to provide referrals. This is according to National Suicide Prevention Lifeline 2008. So the purpose of this evaluation, and I'll go over it briefly, there are limited completed program evaluations for suicide prevention hotlines, and this program evaluation is beneficial given the need and budget funding constraints. 6 research questions are formed based on inquiries from the program stakeholders about the appropriateness and appropriation of continual and increased funding. 1, is the program preventing suicides? 2, reducing suicides. 3, are there other suicide prevention services that should be created in the foundation of this program to increase accessibility, increase effectiveness? Another question, did the individual's crisis subside after speaking with the call responder? And last question, was an additional need identified during the call warranting a referral to another program? To address and answer these questions, the evaluation will include these objectives. The person's emotional state and level of satisfaction with program involvement will be evaluated at the beginning and end of the call and 2 weeks after the call to determine their psychosocial status, well-being, and connection, participation to resources and referrals. Operationalized variables, objectives, and goals for the program evaluation include assessment and study of reduction and alleviation of caller distress as an immediate short-term outcome, development of a safety plan, coping mechanisms, and support systems as a midterm outcome, and connection to relevant and effective resources to address the crisis and distress, while providing continual and further support to the caller, as well as solicit family, community, and public awareness, involvement, and intervention as a long-term outcome. The scope of the current evaluation is as follows. This program evaluation is a quasi-experimental, formative design analyzing data with descriptive, including mode, median, mean with tables, graphs, and charts, which is the quantitative, and inferential qualitative statistics with non-probability extreme purposive sampling. Extreme sampling is useful and can provide the purest insight into a particular studied phenomenon that provides direction and lessons for future research and best practices. Mixed methods will be used with the pre-test, post-test, and follow-up, which is a OXOO compilation design. The dependent factor is the client, representative of the O, and the X is the independent factor, the intervention being provided by the suicide prevention hotline. Again, with a pre, post, and follow-up period to measure the client's condition and the effectiveness of the program's intervention. Cultural competence of evaluators. The evaluators will be representative of the demographic community being evaluated. That includes veterans and the LGBTQ community, etc. The evaluators will be trained and tested in the culturally responsive theory, practice, and holistic framework that promotes obtaining knowledge in program culture, client culture, and knowledge of diverse and lived experiences based on gender, age, ethnicity, religion, native country, language, sexual orientation, communicated identity, socioeconomic status, etc. The evaluators will be able to identify with the caller from a shared empathetic lived experience while recognizing their own cultural experiences, preferences, and representations in a democratic fashion and with social engagement and responsibility. Description of evaluation: inputs, resources, and activities. Funding will be an input to compensate a total of 6 evaluators, 2 to complete the quantitative tool, 2 to complete the qualitative tool, 2 to review and interpret the results, findings, and complete the final report. The evaluators will be compensated for completing the ASSIST training and the CSSRS risk assessment questionnaire training for the quantitative tool of 4 questions, and to review the Lifeline, National Suicide Prevention Lifeline, and American Association of Suicidology guidelines, standards, policies, and practices, while becoming familiar with program services and demographics to understand characteristics and attributes. Funding will be allocated to current program staff who assist in the development of additional resources for the community to campaign and champion suicide prevention. Outputs. Outputs include a steering committee, monthly meetings, and an action plan meeting that involves stakeholders and evaluators to discuss status, documentation, progress, and results. Through this process, collaborative partnerships between stakeholders and community members will be created and maintained. Evaluators will be trained and program staff retrained on policy, standards, practices, and guidelines for optimal suicide prevention. A log will be composed to capture communicated and observed information during the meetings and evaluation period. Outcomes. The short-term outcomes include the program's ability to provide the caller with stress and duress relief, with the felt compassion and empathy provided by the program's staff. The midterm outcomes will be the caller's establishment of a safety plan, identified and communicated resources, and support people who are available and accessible during and after the caller's time of need. And the long-term outcomes include the program achieving goals and objectives in the mission statement to provide effective crisis intervention support and resources to the caller, their family, and the community. Through the manifestation of the short and midterm outcomes, additional awareness and support will be brought to the program, with the probability for additional funding to the program. Outcomes are also identified by increased program staff, community, and public awareness of suicide prevention with signs, symptoms, and ways to intervene effectively. The encouragement and initiation of research studies to examine the need, capacity, and effectiveness of hotline programs, interventions, and effectiveness will be derived as a long-term outcome as well, while supporting continual accreditation and further evaluation research. Staff and community members will be apprised of applied suicide intervention skills training, a training to recognize risk factors for suicide, respond to increase immediate safety, and link to resources. And I believe that training is free. You can complete it online with a 2-year certificate of completion. And I researched that, and it was very fascinating. So please Google the ASSIST Applied Suicide Intervention Skills Training Program for more information. Impact statement. Ultimately, the long-term outcome of the program evaluation will demonstrate the program's ability or further need to reduce and eliminate suicide. To assist with this process, it is essential that the program receive additional funding to sustain its life-saving impact on suicide prevention. It is anticipated that the caller will be positively impacted by program involvement in preventing suicide and increasing well-being. Program staff and service providers will be impacted and strengthened with involvement in this life-saving program and funding sources. The community and society will be impacted to become further involved in investing time and monies to essentially save lives. as well as include a chat text service to the program. That is an available platform designed to track data on calls placed to suicide prevention hotlines, available 24 hours a day. The calls can be tracked, standardized, and recorded via iCarol, and it is anticipated that the program will utilize funding for paid staff, offer incentives and accommodations for volunteers who are in a college internship and can receive degree credit for participating in the program as staff. It is proposed that funding from Cal MHSA will be reinstated. I believe that was expired. It was 3 to 5 years. Due to benefits and needs, it is proposed that calls will be recorded and research studies will continue to evaluate the hotline program results. Program staff, interns, and volunteers will continually complete specialized training via Assist to ensure suicide hotline staff have effective communication skills such as positive engagement, reinforcement, reflection, listening, and problem solving via evidence-based approaches. It is anticipated that implemented, standardized, and consistent follow-up calls attempts will be made to each caller to inform and measure program effectiveness in decreasing caller distress and ensuring participation in referrals. Logic model. The goal is to examine the Central Valley Crisis and Suicide Prevention Hotline Program to determine effectiveness in reducing suicides, connecting to resources, and increasing public awareness and involvement for the promotion of increased program funding. The program lifecycle process and pathways leading to outcomes is presented in the logic model with findings, recommendations to explore, observe, and explain change agents. With improvement, resource connections, increased public awareness, willingness for funding sources to invest in the program as clients, evaluators, and stakeholders move through the program. And these include evaluator and stakeholder collaboration for plan, program, intervention development with input solicitation, evaluators learning about the program with training for client demographics, population, services, policies, procedures, practices, and testing instruments, evaluators using qualitative and quantitative testing instruments to decipher client improvement as communicated by client and exhibited during their participation in referred resources. Information will be logged daily and discussed monthly during stakeholder meetings with research findings, lessons learned, practice implications, and recommendations provided via a visual circular logic map to be included in the final report. Evaluation design. Systems theory and theory of change with an outcome framework are used to inform evaluators of interventions to change behaviors in complex systems. Evaluators will understand the environment of programs with a concrete plan of what is needed and missing in the change process. Evaluation questions. Quantitative design with the use of the C-SSRS risk assessment scale, the Lifeline Crisis Center version, which is a 3-page questionnaire implemented at the O, dependent variable time, the time of initial call and before the application of the intervention. Independent variable is the X, and the C-SSRS risk assessment scale, same scale, will be implemented again after the intervention, which is a O. And then a qualitative design will be utilized with a telephone interview constructed of 4 semi-structured questions during follow-up period, which is the O, dependent variable, that is, how have you felt since your call to the crisis hotline? Question 2, are there areas in your life that have improved since your call to the crisis hotline? Question 3, are you receiving support and services now for the crisis that led to your call to the hotline? 4th question, was calling the crisis hotline helpful for you during your time of need? So again, this is going to make up the design, which is OXOO, using mixed methods. The quantitative method is the C-SSRS risk assessment scale, Lifeline Crisis Center version. The qualitative measurement will be 4 semi-structured questions that will be asked during the telephone interview. Both measures will be used, tools will be used via the telephone with the caller. Evaluation design. The Columbia Suicide Severity Rating Scale Risk Assessment, which I just talked about, the CSSRS, the Lifeline Crisis Center version questionnaire, will be used that is evidence supported and part of a national and international public health initiative involving the assessment of suicide. It is available in 103 different languages and successfully implemented across many settings in several versions. The risk assessment version is 3 pages, with the first page focusing on a checklist of risk and protective factors, which is designed to be completed following the client caller interview. The next 2 pages are the formal assessment. The risk assessment helps establish a person's immediate risk of suicide and is used in acute care settings. Training is available for the tool via a 30-minute interactive slide presentation and question-answer session, or a DVD of the presentation, with receipt of a certificate of completion for this free training that is valid for 2 years. The qualitative design will feature 4 semi-structured questions for client feedback during the follow-up at 2 weeks, making an OXOO design. Both tools address and answer the goals objectives that form the program evaluation research questions. Have funds allocated for the program been helpful with preventing, reducing suicide? Useful with increasing public awareness and social responsibility? If funding has been utilized appropriately, if there are other areas where funding could be allocated, and if the program has sustainability and/or needs improvement. Data collection methods. Collection, a one-group quasi-experimental design with 3 measuring points. Pre-test at beginning of call to determine caller status and need. Post-test at the end of call to determine if crisis intervention, such as provision of empathetic, reflective listening, emotional support, collaborative problem solving with an identified action plan, was effective in reducing callers' distress during the call, and a follow-up period for further assessment using qualitative design via telephone interviews and all caller contact occurring via telephone at the program's office. Confidentiality will be ensured with no names and a number assigned for coding of the quantitative tool. The telephone interviews qualitative method are audio recorded and notes taken to transcribe after interview. Analysis. An SPSS statistical software for bivariate statistics will be used to analyze, understand the quantitative data and relationship between variables, such as the crisis caller and intervention provided. The in vivo software program will be utilized to analyze the qualitative data. Codes will be assigned and 2 evaluators will review daily work at the program office to ensure accuracy in analyzing trends, themes, insights, responses, patterns, comparisons, and contrasts. Intercoder reliability is used to provide consistency with the interpretation process among different coders and with the codebook. Interpretation. Intercode inter-rater reliability will be used with statistical testing and analysis. 2 evaluators will interpret, disseminate, and complete the process. They will report the research findings and results while understanding the importance of the evaluation and the potential impact to the community. Member checking to be completed by the entire evaluation team, 6 in total, to ensure accuracy prior to convening with the stakeholders and completing the final report. Budget and timeline. Evaluation team to be composed of 6 non-employees or staff members, non-staff members who are contracted outsourced evaluators. They represent the program population either directly or indirectly with lived experiences and knowledgeable about the program to ensure objectiveness. Funding will need to be given to the 6 evaluators for each individualized task, and the compilation of the report to ensure inter-rater and coder reliability, with 2 completing the quantitative component, 2 completing the quantitative component, and 2 analyzing and interpreting the findings with composing the final report. Data collection management. To maintain strong methodological integrity with the design, collection, management, interpretation, and dissemination of the data, it will be immediately reviewed and interpreted to measure treatment and outcomes and strengthen validity and reliability of data. Pilot tests will be conducted on both quantitative and qualitative testing instruments to ensure validity, credibility, reliability, generalization, transferability, and auditability. Implications for the program will be discussed with future suggestions and recommendations. Data will be protected and stored on a locked computer software program system with a password, which will be deleted after use. Data analysis, management, and interpretation. Maturation and testing may be threats to internal validity due to possibility of improvement over the course passage of time and by means of exposure to the testing process in itself. The iCarol, a commercially available platform designed to track data on calls placed to suicide prevention hotlines, will be explored and discussed within the evaluation report for possible future use. Communication and reporting with reporting management. To ensure maximum collaborative communication and dissemination of information on progress and status, an initial steering committee meeting and routine meetings with stakeholders will be conducted. Communication will include proposing the use of recorded calls for coding and analyzation in lieu of real-time live calls. It is anticipated that additional studies will need to be completed for further research on findings results. Communication will be conducted to discuss increasing and enhancing the training that crisis hotline staff receive to streamline and ensure consistency. Results will be organized in a manner that answers each question and addresses limitations to the study. The conclusion will be supported with factual evidence from study results, and the stakeholders will be informed of each step and result proactively. Evaluation budget and timeline. With the $40,000 budget, monies will be allocated at 2-month intervals to compensate the 6 evaluators for training and evaluation time, materials needed to record, track, analyze, and interpret the results, as well as written materials, software programs, and community resources needed to complete the process. $5,000 will be allocated for unforeseen and necessary expenses, kind of, as a backup there, out of that $40,000. Timeline. With the 8-month timeline, the stakeholders and evaluators will meet monthly to ensure cohesiveness and continuity with program request. In addition, scheduled meetings will be conducted at 2-month intervals for a total of 4 to be devoted to the measurement of identified plans, goals, status, and needs. For example, the first meeting at the 2-month interval will discuss specific plans for the evaluation and next steps. The second meeting will be conducted, and this is at the 4-month, prior to the evaluators initiating the data testing and collection process. The third meeting at the 6-month time period being held after the evaluators analyze and interpret the results, and the fourth meeting, which is at the 8-month time mark, discussing the findings, results, compilation of the final report, and steps in moving forward. The evaluators will maintain a standardized progress log to be updated regularly and given to stakeholders during the 4 scheduled meetings to obtain input, feedback, discuss the proposal, future study, findings, lessons, and goals in moving forward. So these are my references. Again, I invite you to click on the links to learn more. I want to thank everyone for taking the time to listen to this. I know it's been a lengthy presentation. I think it's extremely important. This is why I wanted to put this out on a YouTube video, at the least to get public awareness and involvement for suicide prevention, so that people are at least aware of the statistics and armed with information on how we can essentially save lives wherever you live, or however you can do that, whether donating your time or money, volunteering for a suicide prevention program, working on one of these hotlines, spreading awareness on social media. So thank you so much again for your time, and all the best to everyone. Peace, love, and blessings.